Okay, and we are live. Hi everyone, thanks for joining and taking time out your Wednesday evening. So if you've been informed, the rules are always the same. So this is going to be a talk by Dr. Yathu Maheswaran. If you're watching on the Facebook, at any point feel free to comment, put any questions, and Yathu will get to them when he can. And if you're in the Zoom chat, any questions, comments, put them in the Q&A or the chat, and Yathu will get to them as he does. But otherwise, pretty chill session. And off to you, Yathu.
Thanks, Ehsan. Thanks very much. So hi, everyone. As Ehsan said, I'm Yathu. I'm a junior doctor working in the West Midlands at the moment, just coming to the end of my F2 year. And what we're doing during this talk is to kind of address one of the key areas that new doctors find cause them quite a lot of anxiety. It's something that you can't really avoid, and it is something that you'll have to do when you start working. And that is requesting scans, investigations, making referrals to other specialties, and also escalating to seniors. Now, why do these areas cause anxiety? Well, I think it's because doctors often find that when you have to speak to a senior colleague or speak to someone that's got a bit more expertise, they're scared of coming across a bit silly, or scared of being asked questions that they don't know the answer to, scared of missing out details, or scared about getting grilled by a senior colleague about something that they don't know about. So that's kind of one of the things why we wanted to deal with this as well, why we're going to do this talk. So in an effort to kind of allay some of these anxieties, what we're going to do is we're going to dedicate the first portion of this talk to referring to specialties. Then we're going to talk about escalating to a senior, and then also requesting scans. And the way we'll do it is we'll use some clinical scenarios and then get you to think about what details you think are relevant from the story, which I'll put up on the screen, and then what you might go on to say to a senior colleague. Is that all right? As always, at the end, there'll be time for sort of general questions, and feel free to kind of slip into my DMs or slide into my DMs and kind of message about sort of anything, other queries that you've got as well. Okay. So this is the general structure. So introduction, where I'll sort of speak to you for a bit. Then we'll go through some clinical scenarios, going through referring to specialties, requesting investigations, escalating to a senior, and then there'll be a little bit more wisdom at the end, and we'll open the floor to questions from all of you. Okay, this is a disclaimer. Okay, so case one, referring to specialties. So Mr. C is a 45-year-old economics teacher on the surgical ward, post-laparoscopy, that's laparoscopic cholecystectomy. He developed a HAP and has been receiving antibiotics. For the past 3 days, he's had erratic blood sugars on the ward, which are very high in the evening. And your surgical reg on the ward round advises you that you discuss with the diabetes team to help optimize this patient's blood sugars, his BMs. He was previously on a BD insulin regime. That's a twice daily regime of insulin. Okay. So that's the information you have at the moment. And with that, your reg has said, we want you to discuss with the diabetes team. Are you happy with the amount of information that you've got there? Would you be happy to speak to a senior colleague or speak to a specialist with that information, or would you want a bit more information to hand? Okay, yeah, you want to go through his notes. Perfect. Good. So you then try to get a bit more information. So again, we've got a bit more information here. So he developed a HAP. He's been receiving IV colmoxiclav for the past 3 days. Erratic blood sugars, they're very high in the evening, around 25, and in the morning they're around 4. So he's having hypos in the morning as well. Okay. His background, has got type 1 diabetes and previously on a twice daily insulin regime. Currently, since his operation, he's resumed eating and drinking as normal, which is important, and he's also on his normal medication, so he's taking that insulin as normal. His hospital-acquired pneumonia is improved with IV antibiotics, he's being stepped down to oral antibiotics, and the rest of his bloods are normal as well. So now we've got a bit more information going on. We know that he's taking, so now we know that he's got these erratic BMs, but the problem is he's got these BMs whilst he's on his normal medications and whilst he's eating and drinking as normal. So that's now a clinical question. Our question to the diabetes team is, why is this patient having these this pattern of blood sugar levels when he's on his normal insulin regime and he's eating and drinking as normal, and what can we do about it? Okay, so that's why it's quite important to get as much information as you can, so that you know that you're asking a question that needs to be asked, and that you are capitalizing on that specialist, their area of expertise, as much as you can. Okay. So, these are the details that are important. So his age is important, the fact that he's post-op is important, his medication is important, what his blood sugar levels are is important, his past medical history, and also the fact that the rest of his bloods are normal as well. So that's all important, okay? What are some other things that you want to consider? Now, I've put them up on the slide, so you can read through them or you can just listen to what I'm saying. So lots of things are important. Firstly, has he been seen by the diabetes team before? What is a question that needs to be answered? We've already gone through the case, so we know what the question is. If this was a case where you weren't sure why you needed to speak to the specialist team, then that's always the case that you want to clarify with your senior. Why am I asking this question at all? And also, what do you want from that specialist team? Is it that you want them to review your patient? Is it that you want some advice from them? So you would ask them, is this an okay plan? And then they would say, yeah, that's fine, you can do that, or they would advise you what to do. Or do you want their team to take over the patient? So is it a surgical patient who no longer has any surgical issues, and actually what they have is a medical issue, and so they would be better off with the medical team? And also, before you phone, always make sure you've got the notes and you've got the bloods, and you're at a computer terminal, so you can have a look through and answer any other questions that the specialist has got. Also, it's important to think about what whoever you're phoning, think about it from their point of view. So what do they want to know? They want to know how unwell is the patient? How urgently do they need to be seen, if at all? Can they be seen later this afternoon, or do they need to be seen right now? If it's a case of what investigations have been done already. So we know the bloods have been done. You might have a latest blood sugar level for your patient. And also, is this the right person you're calling? So is it right that you're phoning the diabetes team? Is it right that you're speaking to the endo and diabetes reg, or should it be somebody else that you're speaking to as well? Okay. Now, let's go into how you might structure what you're saying. And I'm sure a lot of you will be familiar with the SBAR approach. That's SBAR, which we're going to go into a little bit now. Okay, so, okay, we'll go into things to consider a bit later. So, situation, okay, background, assessment, recommendation, and then I put a little R on the end, which is response or review. Okay, so the situation is where you talk about firstly who you are, why you're calling, and briefly say what your reason is for calling this specialist, and say because it's a patient who's got this problem. Okay, then you go into the background of the situation. So what is the patient's significant past medical history, and anything else that is relevant to the colleague you're speaking to. Then go into your assessment of the patient. So clinically, how are they at the moment? It's best if you've gone to see the patient yourself. Are they really unwell at the moment? What are their current, you can talk them through an A to E approach if necessary. And then a recommendation. So rather than saying, I don't know what's going on, please help, you can say, based on what I've seen from my assessment of this patient, I think this. Is that okay? How would you advise we proceed? And that's something that's quite nice to say to someone that you're referring to, because it shows that you've thought about it, and kind of for your learning as well, it's you seeing how far you can get in a case before you're seeking help as well, which is quite good. And then finally, response and review. So that is documenting sort of, if you're asking for someone to come and see the patient, when will they come and see the patient, in what time scale, and making sure that you document who you've spoken to, their role, and their contact details in case someone else in your team needs to follow up on what you've done today. Okay, so we'll go through that SBAR now. So, hello, I'm Richard. One of the upper GI F1s. Is this the endo FPR, so registrar that I'm speaking to? We've got a patient on the surgical ward with erratic BMs who I'd like to discuss with you. Is now a good time? So there you've said the situation, who you are, why you're calling, and what the problem is, and you're seeing whether or not your colleague is free to speak to you at this time. Okay, and doing this is much better than just launching into your spiel the second someone picks up the phone. It does happen sometimes, so just be wary of that. Okay, fine. So background, so we're going to go into a little bit more. So he's a 45-year-old gentleman who's 4 days post-lap coli. And you talk about his background, So he's got type 1 diabetes and what his normal insulin regime is. And then you say he's eating and drinking as normal on his usual medication. Okay, so now whoever's reading this has a little bit more information, and they know that he's on that insulin regime. He knows he's eating and drinking as normal. Okay, then your assessment. So what you've had a look at the patient and you can tell him a little bit more about what's going on. Okay, and this is what we've spoken about just now. And then you go into your recommendation. So if you've thought about it, you could say, we are planning to increase his morning insulin by this amount by 20% and decreasing his evening dose to prevent the morning drop in BMs. I want to clarify whether or not this is the best way to address the issue. If not, how would you advise we proceed? And that shows that you've thought about it and you've tried to think of a plan and do something. And that makes it better for your colleague who you've spoken to as well, because then they can be guided based on what you've done as well. And then finally, you document what the specialist has said. That should say what, not when, and if they will review the patient or not. If they say they don't need to review the patient, document that as well, and then take down the contact details as well. And we'll talk about why taking down those details is a bit more important later on as well. And this might be what that discussion looks like in the notes. Now, this isn't a complete documentation. I haven't shown what the actual plan was, but this is kind of the key details. So date, time, what location, who you are, which is a heading there, to say you contacted the diabetes endo reg, what their bleep number is, and then what the advice was, and then when he will do it. So he'll review the patient this afternoon and then your details as well. Some of you might get a nice shiny stamp when you start working, so you can just put that in the notes. Perfect. Okay, so that's what that would look like. Okay, so just got a question here. What's going on? So I've got a question here. It says, does every doc have their own unique bleep? No. So, and it varies from hospital to hospital. So in some hospitals I've worked in, every member of the team has a bleep and that stays with you throughout. However, when you go on certain shifts, so if you are the medical registrar or you are the medical SHO overnight, then there is a specific bleep that you will pick up and carry around with you, because everybody will know that so bleep 3303 is the med reg bleep, and so that's the one that you'll pick up when you're doing your on-call shifts. And likewise, certain teams will have their own bleep. So there's the cardiology inpatients bleep, or the gastroenterology endoscopist bleep. So yeah, not everyone has their own bleep all the time, but you should get your own stamp, hopefully, which is all very nice. Okay, so the key points there is just kind of remember to introduce yourself and kind of state the reason of your call before you make your referral, rather than just launching into your spiel, and just check that whoever is sort of you're speaking to, that they're not in the middle of clinic or something like that, and that it is appropriate for you to speak to them. Have a key question in mind. There's no point just phoning someone and saying, help, I don't know. Say, I'm seeking your help because, and ask what the question is, and also structure your request, because it's much easier for a specialist to distill that information and hone in on what the key points are when you're speaking. Okay, fine. Is everyone happy with that? If there's any questions, any doubts, just feel free to put them up in the questions tab or message me privately. Okay, so case 2, an urgent review. So you have a 64-year-old female who arrives with acute onset left-sided weakness and dysarthria. Her past medical history is hypertension. She's got AF and she's warfarinized, and she has a TIA, or she had a TIA in January 2015. She had a CT head on admission, which showed an intracerebral hemorrhage on the right hemisphere, in the right hemisphere, with mass effect and midline shift. Sort of a preliminary investigation, airways patent, breathing, bilateral air entry, there's no additional sounds, heart rate's quite low, and blood pressure is high, 200/100, and there's irregularly irregular pulse, AF, and also GCS has dropped. It was previously 14, now it's 11, blood glucose is 7. There's no external evidence of head injury, there's no visible rash. However, the neurological examination shows ongoing left-sided weakness, and importantly here, she appears to be deteriorating. Okay, so important to note here, when we think about what the key details are, is that this is a deteriorating patient. Okay, so before we go any further, just have a look at all that. That's all the information that you've got available to you at the moment. Just think about what you think are the relevant points, and rather than writing it out in in the box. Just think, or even practice wherever you are, how you might then phone a senior for help. So for example, let's say that you are now making a referral to the neurosurgical team. Okay, so how would you refer this patient to neurosurgery? Okay, and just practice that for a moment or two. Okay, good. So let's move on. So here's another example. So hello, I'm Richard, one of the F1s. Is this the neurosurgical range that I'm speaking to? I'm calling about the patient, go into their specific details as well. And what I should have mentioned previously is just make sure when you are discussing the patient and you're giving them the details, that you do ensure you give them the full name and their date of birth and their hospital number, their hospital identifier as well. Okay. And then, so notice in this situation, when you're speaking to your reg, that you're saying, I was hoping you could urgently review this patient. So instantly, you're saying that this is an important situation and you want them to see the patient as soon as possible. Okay. Then we go into the background, where you talk about their past medical history and also what the CT on admission shows. Okay. And then assessment. So you're talking through your A to E approach. So quite importantly, and you're rightfully saying, you're mentioning that drop in GCS, that's a Glasgow coma scale. You're saying that early on because that's important, and you're saying that's dropped from 14 to 11, and then you're going through the rest of your A to E as well, and also the neurological examination. Often when it comes to these neuro referrals, you'll be asked whether or not you've seen the patient, and it's always better that you have seen the patient, that you have examined the patient, so that you can comment on your examination findings. And that's even the case if you're taking, if you're referring on someone else's behalf. If you can see the patient yourself, that's ideal. And if not, just have a look at the notes and see what the most recent examination findings were, because you will be asked about that. Okay, and then you go to your recommendation. So this is your recommendation. So you think that this lady has suffered from an acute intracerebral hemorrhage and is clinically deteriorating. Okay, she needs an urgent review by the neurosurgical team. Could you come and review her? Okay, and then what you would do then is, then if they would say yes, I can come and review the patient, you would then clarify when they can see the patient, in what time frame, and then you would say, in the meantime, because this is a patient that's very unwell, is there anything else that I can do in the meantime between now and when you can come and review the patient? Okay, and that way you ensure that that patient is looked after right up until someone else comes to review them as well. Okay, just got another question here. Yes, so someone said, can you mention the fact that she's deteriorating in situation rather than assessment? Yes, in fact, yeah, you had mentioned that early on as well. So I said, could you urgently review the patient? But yeah, you can bump that up and say, I've got this patient who's deteriorating, please could you urgently review this patient? That's absolutely fine. One of the things to mention here is, so SBAR, which we're going through here in these situations, isn't the only way that you can distill down and organize your thoughts. Some of you may have learned other ways, but the thing that I like about SBAR is it's just a nice way to organize your thoughts. And sometimes if there's a part of your assessment that you feel is really urgent, really, really important, it's fine for you to kind of bump that up in the order. SBAR is just a kind of a way for you to organize your thoughts. Okay, fine. So when we get, so kind of on the topic of referring to specialties, is kind of sum up what we've spoken about so far. Be sure of the clinical question. You might find that on ward rounds, a senior might say to you, discuss this with this specialty and then move on to the next patient. And you might be left wondering, I'm not really sure what we're discussing. Am I asking for advice? Am I asking for a review? Or do you want me to should that team take over the patient? So just make sure you clarify, because that will guide how you communicate with that team, and also it's good for your learning as well. Otherwise you'll just find you'll be making phone calls with no real reason why you're doing it, which is something I don't want for you, and you don't want either. Think about, have you seen the patient? A lot of the time you'll be asked whether you have, and to comment on whether that patient's unwell or not. You won't be able to comment on that if you've not at least seen the patient. And also ensure that colleagues can chase up what you've done. for example, so where I used to work, when you do some surgical referrals or neurosurgical referrals, you do it via an online portal, and then you put your contact details down, and then you'll get an email when somebody has picked up that referral, and when they've commented on it. When you finish your shift, you then put whoever's coming after you, you put their details down on the referral system so that they'll then be contacted if there's any updates on the progress of that referral. So just stay on top of that if that's something that happens at your hospital, so your colleagues can chase up on that referral. Similarly, if it's an email referral system, so you're referring to gastro, for example, by email, just make sure that you copy in your other team members in that email, so that when that team specialist then replies, that the other team members can also see what the plan is, and that's especially important if, for example, you're not here the next day. And also make sure you hand over to whoever's going to be on call as well if they need to chase up on the referral. Okay, fine. So is everyone happy with referring to specialties so far? Any questions or any queries? Okay, perfect. So let's move on. So case 2 and a bit. So this is case 2.3, for example, requesting investigations. Okay, so before we get into the nuts and bolts of the case, let's just talk about requesting investigations. Now, most hospitals, I'd say now, when you're requesting scans, for example, or requesting bloods, they're mostly electronic requests. So you put it into the system and then that will get sent off to the department. So if it's for an X-ray request, for example, but still somebody has to pick up that request and have a look at it and see whether or not they can do the scan. And so the information that you put down on that request will determine how somebody responds to it, and whether they respond to it urgently or whether they'll get around to it a little bit later. As always, more information is better than less. I've seen certain requests where there's literally been one word. And so it's always best to provide a bit more information, a bit of background as well, just so whoever's looking at the referral knows how to deal with that response. Think about, is the test really needed? And this goes for anything, whether it's routine bloods, for example. So, you know, when someone says routine bloods, think about whether or not that patient actually needs bloods, because having your bloods taken is never pleasant. So just think about that, and also think about how, if you do that investigation, how is that going to guide your management of the patient? If it's not going to guide the management at all, if it's not going to do anything for the patient at all, then ask yourself whether or not that investigation really needs to be done. Do those bloods need to be done today, or can they wait another day or so? And also think about how the investigation will affect the patient. And this is what your radiologist will be doing. If you're thinking putting that patient through a CT scanner, again, do they need to be subjected to that amount of radiation? Does this patient need to be bled again? Okay, so just think about that. So the way we're going to think about it is looking back to the case we've just spoken about, which is our 64-year-old female who's come in with the acute left-sided weakness and dysarthria. Now you know which investigation was requested, but I want you to think about how you might request that investigation now. Okay, so there's a question there. I'm just going to get around to it. Okay. So, but before I answer that question, just think about what you're going to put down. If you look at all that information you've got on the screen now, how would you request that CT scan? Okay, so think about what you put down on the electronic request. Okay, and a lot of the time when you're requesting CT scans, you then need to contact a radiology reg or the radiology consultant, whoever's going to be reporting the scan, and so that they can vet the request and the patient can go and have the scan. Okay. So have a look at that for just a moment longer, and then we'll crack on. Okay, good. So your request might look like this, for example. So we're 64-year-old female. So this is what you might type. 64-year-old female presenting with sudden onset dysarthria, left-sided weakness. GCS has dropped. Background of hypertension and AF on warfarin. Please investigate for suspected intracerebral hemorrhage. That's more or less what you might type on the request and send that off electronically or write on the form and then go drop it around. But because in this situation, it's an urgent scan, you want to make sure that it's happening as soon as possible. And you may even have to go down to the scanner with this patient. You would then put a phone call through to whoever's vetting the scan or go around with them and then discuss this with them and say, this is the clinical scenario. We need to do this scan urgently because it's a suspected intracerebral hemorrhage and we think that we may need to get the neurosurgical team urgently involved as well. Okay, and again, like you can see with this request, the details are very it's the key details in it. You're getting all the key details down, and you're stressing just how urgent the scan is. Okay. Yes, you need to stabilize the patient before you're moving them into the CT or for other imaging as well. But you can't have an unstable patient that you're putting through the scanner as well. Okay. And finally, someone's also asked, when would you escalate to your reg rather than a reg from another team? I think generally discuss it with the reg in your team, first of all, before you then escalate to another reg as well. Generally, that's what I would say. Okay. Fine. Okay. Additional tips for requesting scans. So first of all, don't be scared about requesting scans. I think there's always stories that get bandied around about sort of particularly aggressive radiologists or sort of doctors who've received quite sharp words from a colleague over the phone. Don't worry about it. The job of the radiologist is to kind of be sort of the custodians of this resource, which is your scanning equipment, and they want to make sure that if somebody is being subjected to that level of radiation, that it is warranted. So sometimes if they decline a scan or decline a request, it's because simply there's not enough information or you haven't communicated the clinical need enough. I've had situations where I've requested a scan and the radiologist has actually said, no, it doesn't seem like the scan is needed right now. And if that's the case, but you still think the scan is needed or your colleague in your team still thinks it's needed, then it's a case of going back to your colleague. So in that case, I went back to the reg and said, would it be okay if you spoke to this radiologist just about why the scan is, because he wants to speak to you, and that's absolutely fine to do. Okay, but just to make it easier on yourself and also for whoever is doing the scan, whoever you're speaking to, just be confident in yourself about what scan is required, how it will change the management, and how urgent it is. Okay, so you can stress that to the team as well. Also, just a little tip. So when you are on your ward jobs, request scans early so that you can avoid any delays in them getting performed. So try to do your requesting and your referring quite soon after the ward round, because then if you want to see results within that day, then you're more likely to have that happen if you do that requesting and that referring early on in the day as well. Okay. So for requesting investigations, know why that scan is required, and the more information, the better, really. But don't go putting reams and reams of text in, because somebody does have to read it, and also request early. Okay, got another question. How long is it acceptable to wait after requesting a scan before calling the on-call radiologist? So in the clinical situation that we've just said, I think once you've put that request through, I would phone the radiologist straight away to say, we've put this request through, because in that situation, it's urgent that you get that scan straight away. So I think with that, it really depends on how urgent the situation is. I think if you put if it's something that's not necessarily urgent, so it's a chest x-ray that doesn't need to be done immediately, but ideally you would like it at some point in that day, you could put a phone through to the radiology department, not necessarily the radiologist, but the technicians, and just say, based on the request and the other requests you've got, how soon is it, or how soon will you be able to do the scan as well. Another thing, just talking about the process as well. So the process of requesting scans is different in different hospitals. The system I'm familiar with is you would request a scan, say is an urgent CT scan, you request a CT scan, you then phone the on-call radiologist or whoever's on during the day, and then you would get them to say, yes, we can do the scan, and they might say to you, can you then phone the radiology technicians and or the radiographers and ask when they can do the scan. You then phone the radiographers and say, the radiologist has just vetted this scan, can we bring this patient down to the scanner? When can we bring them down? So you make those 2 phone calls, and so you know when the patient's getting the scan, and you know that they are going to get the scan, and that you can expect the result. Okay. So for that bowel obstruction patient, I would, even if they're clinically stable, in my experience, I've phoned the radiologist. I phoned the radiologist to find out when they can have that scan straight away, because you want to confirm that bowel obstruction before you then do anything else. Whether they need sort of any urgent surgical management, that will be guided by your investigation. Okay, but when in doubt, again, always do ask your CNE colleagues as well. If you're not sure whether you need to chase it urgently, or whether you can wait for a while. But in that situation, with that bowel obstruction, then I would get them through that scanner as soon as possible. Okay, so let's go on to the next one. So case 3, and this is about escalating to a senior. Okay, and so what I'll preface this section with is, when in doubt, always ask. Okay, there's always something that you can do in these situations, if you do get stuck, that's okay as well, and that's also a good time to ask for help. Don't let the fear of coming across silly, or the fear of being told off, put you off from calling for help if ever you feel that you're out of your depth. Okay, and if you are out of your depth, the main thing that you can do is get as much data as you can. So collect all the information, at least, so it's there, and try to organize that information and present it to whoever you're speaking to in an organized, calm manner, so that they can then pick up the relevant bits and help you put a plan together. Okay, because ultimately that's why you're asking for help. That's why you're asking for someone else's expertise. Okay. And also, just as a whole, so often I think asking for help, escalating to seniors, referring to colleagues, it's something that you may feel that you've not really practiced whilst you're in medical school, or whilst you're on your apprenticeship placements. But it does draw on a lot of the skills that you use when you practiced presenting patients, for example, for your finals. And so it's that same sort of skill set of picking through a big story, or picking through an examination and saying what's relevant, maybe adding in a differential if you've got one, and then suggesting a preliminary plan and asking for advice on that plan. Okay. So it's something you've done before. It is a skill, and with all skills, you only get better at it the more you do, and the more that you think about how you can improve. Okay, so you have a 26-year-old student presenting with a history of headache and with neck pain. Also feels that the bright lights are hurting him, and he feels very, very unwell. So looking at that, I mean, that's kind of a multiple choice question in a way, so you might already have an idea of what the differential is. That's fine. So this is kind of what you see, what you've documented on the notes. Please note that this is not a comprehensive clerking, and this is just kind of a brief summary of points that you might write down. So 26-year-old male, and no, I've just used a few abbreviations here that you might come across in a hospital, and we can talk through those, or if you're not sure what any of them mean, you can ask. Okay, so 26-year-old male, that's a 2-day history of headache, generally unwell, history of presenting complaint. Okay, they want to lie down in a dark room. Okay, so that's suggestive of your photophobia. Okay, no recent travel, no nausea or vomiting, bowels open as normal, past medical history, none, drug history, none, NKDA, no known drug allergy, on examination, airways patent, respiratory rate 16. This means that the lungs are clear. Okay, you'll see this diagram a lot in various forms, some great, some not so good, but that's kind of what it should look like. Saturations are 98% on room air, heart sounds 1 + 2 + no additional sounds, blood pressure, heart rate, GCS, no rash, neck stiffness, and then this is your abdomen, and it's soft, non-tender, bowel sounds positive, so bowel sounds are present. Okay, so again, based on that information that you've got there, just think about how you would present that to your colleague, to your senior colleague, okay, and what you might do. Okay, and so what this is doing is just kind of getting you used to the skill of looking at what your notes are, picking up the phone, and then phoning based on the information that you've got there. Okay. Okay, so what you might say is that I've got a 26-year-old patient who's come in with a 2-day history of headache and feeling generally unwell. I'm concerned because he's continuing to show fever and drowsiness. His on general examination, his airway is patent. There's no evidence of any respiratory distress. However, I am concerned that he might be hemodynamically compromised because his blood pressure is a little bit low, as is his heart rate. GCS is 14, but he's also showing some neck stiffness as well. A preliminary differential might be that this is meningitis. However, I'm not sure how to proceed. Please, could you advise? Okay, so in that situation, you're not sure exactly what's going on, but you come to a differential. You think this might be what's going on, and you're saying what you think it is, and then your colleague can be guided by that. If you feel that they're really unwell or they're deteriorating, and then you might say, please, could you come and see this patient as well? The important thing to say is, don't just say that you don't know. Okay, so it's better to kind of think about it and do as much as you can to make it easier for whoever's help you're asking for. So in this situation, if you think it might be meningitis, then you might give IV ceftriaxone stat, and then discuss it with your registrar. You might then think this patient needs a lumbar puncture, in which case you do a CT head and then your lumbar puncture. Okay, and that's what you would get from speaking to them. The point of this case, what I wanted to highlight was that even if you don't know what is going on, there is still something that you can do. You can always examine the patient. You can always gather all your thoughts together. You can always summarize everything that you've got so that you can present it to them, get all the bloods together, etc. Okay, and that's all important. That's still relevant. Okay, and also you can structure the delivery of your information. These are some phrases that you might use in a situation if you're not sure what's going on. So I'm not sure exactly what the problem is, but this patient is deteriorating. Please, could you come and see them? I'm not sure what the problem is, but I am concerned. Okay, and the fact that you've said I am concerned shows that you have thought about it, and that there is a point to your phone call, and therefore you would appreciate their input. Okay, perfect. So just to conclude that bit, so with escalating to a senior, there is always something that you can do. And as with all of the other two things that we've discussed so far, it's important that you structure your delivery, okay? And don't just say, I don't know, okay? And with all three of these things, the important thing is to be confident, okay? Don't be concerned about coming across as foolish or being asked lots and lots of questions. Ultimately, you're seeking advice from somebody who has a bit more expertise in a certain area than you do. They may need more information, which is why they will ask you questions. It's not an attack on you or an attack on how thorough your clerking is. They just need that information. And so the best thing you can do is put yourself in a position where even if you don't know what that information is, that you can find it out or ask somebody who can get you that information. Okay, so that's just kind of to set you at ease about requesting scans, referring to a senior, and also referring to specialties as well. Okay, so that's kind of the main thing, the main bulk of the talk, really. That's everything on those three sections. So what I'd like to do now is just kind of open up the floor to general questions that you might have about starting FiY1 or moving jobs or moving to a new city or anything, because I realise that from my experience as well, it's a busy time. There's lots of things going on, and there may be things that just people that haven't mentioned to you that you've never really thought about, that you need advice on. So that's what we can talk about for sort of the next while, as some prompts, just things that I was worried about when I started working. I'll put them up on the next slide, and feel free to ask me as well. My email address is also on one of the slides a bit later on. So if you don't want to ask now, but you do still have those queries, feel free to email me, and I will get back to you as soon as I can. Okay, so these are some example questions, just that I thought about, just to, if any of them are relevant to you, let me know. Okay. Okay, so I'll work through these questions. Good questions as well. Okay, so this first question is, as a fifth year medical student, I've heard mixed opinions from juniors or consultants with regards to knowing what specialty you need to do, and whether or not I knew what specialty I wanted to do before foundation years. Okay, so the thing with me is that I have flitted between wanting to do everything under the sun. Since starting medical school, I've wanted to be a child psychiatrist, I've wanted to be a neurologist, I've wanted to be an anaesthetist, I've wanted to be a neurosurgeon, I've wanted to be a radiologist, I've wanted to do obs and gynae, I want to do everything. And that will change, and you don't need to decide straight away. Sometimes some people have a burning passion to do something straight away. Other people just need to be exposed to things a bit more and think about it in the end. You don't need to know straight away, and sometimes getting a bit more experience before you work out what you want to do is absolutely fine. So that's fine. The advantage of knowing what you want to do early on is that if you want to, you can kind of start doing things that will be an advantage. And when you're applying for that job, whether it's getting involved in audits or seeking out taster experiences, but you don't necessarily need to know that. You know, the experience of doing an audit is relevant to all specialties. So, you know, if you want to do obs and gynae, you don't have to do an obs and gynae audit, because the skills of doing an audit you can get from doing anything and familiarizing yourself with the process. Doing well in your exams is important for all of your specialties. So you don't need to worry too much about knowing what specialty you want to do straight away. But what I will say is that choosing what specialty you go on to do isn't a passive process. It won't come to you as an epiphany, and you do, having gone through it myself, you do really need to think about it, try it out, see what you like, see what you don't like, and kind of narrow it down that way, because otherwise you'll just carry on progressing and you won't be sure. But certainly as a fifth year student, don't worry about knowing what you want to do at this moment in time. I didn't know what I wanted to do. Okay, and that was a really long-winded answer, sorry about that. Okay, so let's go to more. So how do you find time to be in the ward but also getting theatre time? Okay, so on my surgical job, we none of us were budding surgeons, but we still got some theatre time. And the best way to do that is just let your colleagues know that it's important to you to get some theatre time. Okay, and that way, on a certain day, if it's a quiet day, for example, you might say, okay, so we'll get through most of the jobs today. You can, on this afternoon, go off to theatre, but then on another day, you would then stay on the ward and do the ward work while someone else gets to go to theatre. But you can't go to theatre without getting through the bulk of the jobs that need to be done on the ward. And if it is a particularly busy day, then the priority is your team and being on the ward and getting that ward work done before getting some theatre time. But it is something you will negotiate with your colleagues as well. Okay. Is there anything you would suggest revising over before starting on a gastro ward but haven't been on a ward since February? Okay, yeah. I mean, sort of, there are lots of things you can do. I think kind of having a flick through ALS, that's advanced life support, is always something that's quite important, just to kind of familiarize yourself with that. And also, I think that this book is quite useful. And so if you're a foundation doctor, so that's the Oxford Handbook for the foundation program. I'm not paid to endorse that book in any way, but it's something that I found quite useful during work as well. There's lots of handy tips in there just about kind of common scenarios that you might experience on the ward, advice on how to organize your time, and general tips. So I found that quite useful, and actually I use that as one of my references for this talk as well. Okay, but other than that, if there's any areas that you're really not sure of, then always flick through them. But I think kind of your medical emergencies are the ones that you kind of want to be best at. Okay, so a question about how early in advance do we need to take annual leave? Again, that will change between wherever you work. Realistically, take it as early as possible. If there's some dates that you absolutely need to be off, then you submit that to your rota coordinator as early as you can. So even before you start work, they may not be able to guarantee that you get that leave, but then when you start working, and you feel like you need to switch as on-call shifts, as always, the earlier you request that, the better. Okay, and I'd say kind of you want to do it with at least like 6 weeks grace. Okay. Did you get quite a lot of support teaching throughout your F1, F2? I actually did, yeah. But I think, and this goes back to kind of one of the tips that I'm going to say later on, is that in terms of teaching, you'll find that you get taught opportunistically as you go along, and you get there by showing a keen interest, okay, and asking questions. So if you see a clinical situation on the ward round and you're not sure why something's being done to manage that patient, ask, because then somebody will take the time to explain it to you, and that's kind of the most important thing. We always had protected teaching time, and so it's always best to go to that teaching. If you find that your job is so busy that you can't attend that teaching, then that is a problem. That's something that you need to escalate, because it may be the case that you're being burdened with an unfair workload, in which case there are people that you can speak to about that to make sure that you do get to go to your teaching. Okay, how do you plan your taster week? So it depends on which specialty you want to do, but generally what I did was I wanted to do an anaesthetic, so I spoke to one of the anaesthetic consultants, and he put me in touch with his colleague, who's one of the college tutors, who is kind of one of the doctors who's in charge of kind of educational things relating to that specialty, and then he helped to organise my taster week. But the best thing to do is just send the emails that are relevant to that specialty, express an interest, say you're keen for that specialty, kind of what experiences you would like, and then they'll help to organise that with you, and that will be part of your study leave allowance. Okay. Is there funding to do taster weeks, i.e. accommodation? Not that I'm aware of. I'm actually not sure about that myself, but I think when you do start working, if you just speak to the postgraduate team, they'll be able to advise you, because I think that's something that changes between trusts. As far as I'm aware, I don't think that there's funding, but I think that will be something to speak to kind of your local team about that. Okay, how do you normally spend your time after a full day at work? Okay, so again, it's important to kind of have a life outside of work, so do something to take your mind off, do something to relax, and it changes. Some days I like to come back, and just catch up with my friends. So whether that's you go to the pub, going out to dinner, I mean, not anymore, not these days, but back when the world was normal, or just catching up with them over FaceTime, or sometimes I like to come back and just sort of chill out with a book, or go for a run, or anything, just something to kind of take my mind off things. It's important to have hobbies too, so we have a hospital football team, so we play football, and that's kind of just another thing that gets us together, but also just keeps us active and busy outside of work, and it's something nice to do. Cool. Okay. Okay. Fine, carrying on. Do you know anyone who managed to do a research paper on publications during FY1? I mean, people do research papers and publications, and they're very, very active and get lots and lots of things done during their foundation years. But I think what I'll say at this point is your priorities during your foundation years are to learn how to be a competent, confident, and a safe doctor. Those are your main things. So and that comes easily to some people more than others. Some people may find that in their free time outside of work, after they've done a good job at work, they want to come home and they just want to take it easy. And other people might want to come back from work and really focus on their CV and things. And that's entirely up to you. Just because certain people are doing it doesn't necessarily mean that that's for you. So just take that with a pinch of salt. Not everyone is going to do all those research papers and get things published. But that said, I think it's always nice to just keep an eye on your CV and the things that you are doing outside of medicine. So think about teaching opportunities, think about if there's an audit you can get involved with on your ward, anything like that that's related to medicine. For your applications, I will also say that it is good when you do go for interviews and things, and you will get asked about what you like to do outside of medicine as well. So just as when you were a medical student, it's important to keep those interests, because it shows that you are still a human, and that there is more to you than the job, and that's a desirable characteristic. Okay. Did I enjoy my FY? Yes, I did. I was telling Esan this previously. I absolutely loved my foundation years. I'm actually quite sad that they're coming to an end. I moved from London up to Birmingham, and I was a bit daunted about moving to a new city at first of all, because I spent all of my my university life in London. I was a bit scared about would I make friends, would I like the city, all of those things. But actually, you're moving to a new city, but loads of people are in that same situation as well. So you will make friends really easily. Everyone's in that same situation. I think if you can sort of go out for a team bonding social with your colleagues, fine. You might be lucky that you have quite an active hospital mess, in which case you can go along to those socials as well, and just get to know people and really get stuck in. I think with your foundation years, the more you put into it, the more you'll get out of it, and that applies for both the work and the social aspect as well. Okay. But yeah, there will be people to speak to, and just do everything you can to get stuck in. People are always lovely. There's always someone nice around. Can you only take annual leave on day shifts and not on night twilight shifts? So generally what I will say is that you can only take annual leave on what are classed as normal working days, which are your 9 to 5 or your 8 to 4 or whatever that is. But for night and twilight shifts, you can't just take leave. You will need to swap those shifts with someone else, so to make sure that shift is covered before you can take leave. Okay. But when you're looking at your rotas, if you're just looking for days you can take off without having to swap or anything, your normal working days are the only ones that you can take leave. And you will need to make sure that there's enough cover on your wards as well. Okay. Is it normal to manage a whole ward by yourself as an F1? I think firstly it depends on what the ward is, but also you won't be alone. So there should be other F1s, other SHOs, and there should always be seniors that you can escalate to. If ever you find that you have an unmanageable workload, that there are unwell patients that you simply cannot manage by yourself, that is a reason to escalate, not just in the acuity of that situation, but also to escalate to whether it's the consultant to say there is just not enough staffing on this ward, so that issue can be addressed straight away. Okay. Is it normal for FY doctors to still be studying and revising like they did in medical school? Yeah. So I think so if you're doing exams, for example, then obviously you will be studying and revising like you did in medical school. But I also think that if you find that there's things at work that you want to know a little bit more about and you want to learn about, then it's absolutely fine to be sort of kind of picking up a book, whether it's one of these Oxford handbooks or something a bit chunkier, just to have a flip through and see what's going on. From my experience, my colleagues didn't. I mean, I don't know of people coming back every day and studying, putting in the hours that you did during medical school, because it's not about the exams anymore. It's about being clinically safe and doing what you can in the work environment. So I wouldn't expect to be kind of doing the long hours that you were doing when you were in medical school. But I do think that, it's perfectly acceptable to kind of have a look through those books if there's something you want to know a bit more about. Did you want to move away from London for your junior years? Yes. So I'd spent all that time in London. I loved it, and kind of part of me does want to go back, but I kind of thought that I wanted to have a different experience to see what it was like in another city, because when you move somewhere else, there's a different demographic. When you get different demographics, the medicine's a bit different, but also there's that life experience of actually moving somewhere else and experiencing somewhere different, the challenge of meeting new people, the challenge of just moving somewhere else and getting to know another place, which I found to be really exciting, and I'm glad I did it. Ultimately, if you don't do it, you won't know. That was something that was important to me, but it may not be something that other people feel. But I'm really glad that I moved away for that life experience. And actually, if I hadn't moved, there are some great people here that I've met that I would never have met if I'd not moved. So I'm really happy that I moved. Okay. So on prioritizing jobs, how do you organize this? Okay, so basically the pattern of the working day generally is that you'll do your ward round with you and your team, and then you'll come together and you'll put together a jobs list of all the things that need to be done. The things to prioritize are if there's any acutely unwell patients, that you deal with them straight away, and then on prioritizing jobs, requesting and referring, generally I did as early as I could, just because it gives you more time for people to come around and see your patient, and there's more time for those scans to be done, and then if there were bloods that needed to be done, then we go and do our bloods, just so we'd get all of those done, and then you've got to do your discharge summaries as well. Now the way you get around to your discharge summaries is that obviously there's that pressure to get your patients kind of through the hospital system as quickly and as thoroughly, or most thoroughly as you can. But just remember that you also need to be looking after your patients who are in hospital as well, and just making sure that you're not requesting all their scans at the end of the day and doing all bloods at the end of the day. So kind of, you want to get through things as quickly as possible. If there's patients that can get out of hospital quickly, then by all means prioritize their discharge letters. But we always kind of did our requesting and referring and then bloods beforehand, so that there was time for those to come back before then moving on to our discharge letters. Okay, that's fine, but just make sure you make a list of all those jobs as well, and tick them off as you go. You might see people where they write this list with a little box next to it, and then it's half coloured in if the job is half done. So the bloods have been sent and they've not been chased, and then you colour in the whole box when the task is completed. Okay, and then get together with your team at the end of the day to go through the jobs and make sure they're all done, and any jobs that aren't done, that you put them on your list of patients so that they can be done either by the on-call or done the next day if they can wait. Okay. 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 How do you remember about so many patients when nurses ask you questions? It's not just the nurses; it'll be anyone that asks you questions. It might be a consultant, might be radiographer, a radiologist, microbiology, for example. So what you will do is you'll have a list of. So when you do the ward round, you'll have a list of the patients, and on that list, you'll have a quick summary of the patient, whether it's one that you maintain as a team. So every day you update the list, say Mrs. Jones in bed 4, 72-year-old came in with community-acquired pneumonia, background of whatever. It will say all of that on the list, and then the investigations that she's had and what those results were. And what other things you're waiting for, so that you'll have that list and maintain that list. So stay on top of that, so that if somebody does ask you about it, that you do know about that. But also, kind of in the ward round, if they're quite long, I think just try to concentrate and stay just aware of which patient is which, and so that you're aware of what the plan is, so that you can then speak to someone quite confidently about that patient. How do you know if you've been paid correctly? I think. Generally, I found that with my colleagues, when we were on the same job, if I was being paid differently to my colleagues, then you'd know something was up. I think it's always worth checking your tax code as well. There's always some issues around tax codes when you start working, just because some people have had jobs previously, etc. And if there's an issue, then just phone HMRC, that's Her Majesty's Revenue and Customs, and just confirm what your tax code should be. And it may be the case that you need to communicate that to payroll as well. But I found that HMRC, that's HMRC, were really, really useful at talking me through what my tax code should be, just to make sure that, firstly, you're getting paid the right amount, but you're being taxed at the right level. As well. I can't go into any more detail about sort of tax codes and pay specifically, because that's beyond my expertise. But I think ultimately just check with your colleagues, because you should be being paid more or less the same, or somebody would have done your job before who's being paid more or less that amount. Okay. Got some more questions here. Okay. Okay, is holiday for everyone's a standard amount of days, or does it depend on your deanery? I think it is 9 or 10 days. and then also you get lieu days, so days off in lieu if you work on a bank holiday. So if you work on a bank holiday, then you get to take that day off as additional leave as well, because you worked on a holiday. Okay. Fine. Okay, so that's all the questions. Fine. As always, I kind of have a few slides at the end just about general advice, which we can go on later. This is case 4 about the medical students who become brilliant doctors. That's all of you who will go on to be brilliant, and that's just kind of, you will become a better doctor by trying to be a better doctor. Be proactive. Okay. Have something to look forward to outside of work. Okay, which we've spoken about. Be organized, so keep your lists. Maintain a calendar. You will fall into a routine. It can be difficult at first, but you'll settle into that routine. And be kind whenever possible. It's always possible. Okay. So, hospitals aren't always, there's a lot going on. It can be, easy to kind of get caught up in everything, but be nice to your colleagues, be nice to your patients. You never know when someone is having an off day. And, by doing that, you can ensure that the hospital is a nicer place as possible. Okay. So this is just a list of common bleep scenarios that you might get called to when you start working. And if you've got any other questions, just by all means, send me an email. That's my email address, Yathu@doctors.org. And I'll try to get back to you as soon as possible. And these are my references. So geekymedics.com and the Oxford Handbook. Okay. And lastly, feedback. Okay, so please do fill out the feedback form. It's really important to me and the Becoming a Doctor team. They're doing a fantastic scheme here. And so do feedback. If you liked the talk or if you absolutely hated it, that's fine. My tears will dry. Just let me know, that's fine. Okay, so please fill out the feedback form by scanning this thing. And if I just change my name to my email address, and my name on Zoom to my email address, and then you'll be able to send me your questions. Okay. That's Yathu Maheswaran at doctors.org.uk. Okay. I'm just going to go off the feedback slide from, oh yeah, it's fine. It's up on the chat. So Yathu Maheswaran at doctors.org.uk. Becoming a Doctor, I've just put it up on the chat. Okay. So we'll leave that up. And if there's any other questions, please ask away. I'll stay on for a few more minutes. If you have any other questions. And just in the meantime, while you are filling out that feedback, kind of going over the 4 points that I always put at the end of these talks, just because I think there's lots of tips and things that people will give you, and you'll settle on what you think or what you find to be the most useful. But generally, the things that I think someone had told me when I started, the things I've just mentioned, which is kind of, you'll become a better doctor by trying to be a better doctor. So kind of get stuck in, get really involved, really, really try and do as much as you can, because that's how you'll learn. And you ultimately get better at the things that you do again and again and again. Okay. I can't stress enough the importance of having something to look forward to outside of work. Because there will be days that is really, really stressful. And it happens, everyone has a difficult time. And it's so important that you have that activity that can take your mind away from work. That's where you can just be you and relax. Whether that's talking to your friends about, things that you've seen at work, or talking to your friends about things that you haven't seen at work, or activities, anything. It's really important that you have those things. Being organized. You might find that people, say, be organized, and they say it so often that you're not really sure what that means. That can be lots of things, whether it's making a list of tasks, whether it's putting your rota into Google Calendar, whether it's scheduling the day that you do your laundry and the day that you go shopping, just to make sure you don't go into work wearing damp socks. It does happen sometimes. Just you'll settle into ways. I like to sit down at the beginning of the week and kind of plan which days I'm doing things, and that really helps me. But other people might not find that's useful, so you'll find your own way. Okay. And lastly, it's that thing about just being kind whenever you can, because someone is always having an off day. And that's fine. Okay, so fine. We'll just take this last question here, which is, what was the transition from 5th year to F1 like? And do you think your 5th year, or do you think your final year prepared you well for life as an F1? In a way, yes. I think kind of the way that you go through preparing for finals, putting in that teamwork of preparing, practicing your OSCEs together, going into placement, a little bit more, you can answer questions from your consultants, and your medicine. I think that really helped me for preparing to F1. That said, there are lots of things that you can only really learn from doing your F1. Okay, so that's kind of what the shape of your general day is like, and certain things like speaking to patients about certain things, because you can only really do that when you've got the responsibility of being an F1. I found that I only really felt I was properly part of the team when I actually started working, and there was so much learning when that comes with that, because then you're trusted to do a certain job, and if you don't do that job, then no one else is going to do that. And so I find that to be quite a good, useful environment. And also spending so much time in the hospital, you learn, you learn where things are in the hospital. You learn how little tricks and tips and how to get things done a little bit quicker, shortcuts, which are kind of specific to your workplace, which you can only really learn when you start working. Okay, perfect. So that's everything. That's the end of the talk. If there's any other questions, feel free to email me. It's up in the comments. I'll just put that slide up as well, that slide. Otherwise, it's been great. And I wish you all the best of luck in your future. And maybe I'll see you on the wards at some point in the future.